Hello, my name is Laura Garces. I'm going to talk about a randomized trial of protocol-based care for early septic shock. First definition. Septic shock is a disease that occurs when an infection causes dangerous low blood pressure. These conditions can be caused by any type of bacteria. The body responds in an inflammatory way to toxin, which can lead to organ damage.
Sepsis is a life-threatening clinical syndrome that develops when the body's response to infection injures its own tissues and organs. Clinical criteria for diagnosing sepsis were first proposed in 1991 and last updated in 2001, but a lot has happened since. So now, a task force of critical care, infectious disease, surgical and pulmonary specialists has published the third international consensus definitions for sepsis and septic shock that take advantage of advances in the science of sepsis and the ability to test proposed sepsis criteria against patient outcomes using electronic health records data. The group defines sepsis as life-threatening organ dysfunction caused by a dysregulated host response to infection. In clinical terms, patients with sepsis have suspected or documented infection and an acute change in the sepsis-related organ failure assessment or SOFA score of greater than or equal to 2. The group recommends use of a bedside score, the quick SOFA or Q SOFA score, comprising an increased respiratory rate, alterations in cognition, and low blood pressure, to identify patients outside critical care settings with suspected infection likely to have poor outcomes typical of sepsis. Finally, they define septic shock as sepsis with abnormalities in circulatory physiology and cellular metabolism in the absence of hypovolemia, profound enough to increase mortality. The authors acknowledge that there is no reference standard for diagnosing sepsis, and that the definition of sepsis is and should remain a work in progress.
Application in medicine. Patients with severe sepsis or septic shock in a single urban emergency department mortality was significantly lower among those who were treated according to a 6-hour protocol of early goal-directed therapy, EGDT, than among those who were given start therapy, 13.5% versus 46.5%. Pros. The protocol for EGDT calls for central venous catheterization to monitor central venous pressure and central venous oxygen saturation, which were used to guide the use of the intravenous line fluids vasopressor, concentrate red blood cell transfusions, and double time to achieve specific physiologic goals. Cons. Our study protocol specific threshold for vasopressor use, but not the specific choice. The protocol guided only resuscitation with all other aspects of care, including the choice of antimicrobial agent at the discretion of the treating physician.
The medical team in this intensive care unit at Mayo Clinic is on high alert 24/7, watching for signs of sepsis.
Sepsis is a potentially life-threatening complication related to an infection.
Dr. Canon Ramar says every year, close to 750,000 people in the US develop a septic reaction. It happens when an infection prompts the immune system to kick into overdrive, causing problems such as kidney failure, liver failure, severe drops in blood pressure, and even death.
It becomes very important that this is recognized early.
That's because the death rate can be very high, up to 75% for people who develop sepsis at home, and up to 25% for those who get it in the hospital.
It's almost similar to treating a heart attack or a stroke, where you have a very short window. Okay, I think let's go ahead and activate the sepsis response team.
We have a patient in room number 20. We want to activate the SRT.
So it's a big multidisciplinary approach to do this. And so all members of the ICU team are actively involved to get this aggressive resuscitation going. Let's get the central line ready.
We did give a dose down in the ED, so continue with that.
We follow what we call as the surviving sepsis resuscitation guidelines.
Methods of best practice developed by the Society of Critical Care Medicine to ensure the best possible treatment for patients.
If the necessary things are done, then the mortality drops down dramatically.
Sniffing out sepsis and saving lives. For Mayo Clinic News Network, I'm Vivian Williams.
Issue applied in Ecuador. In the ICU service of the Enrique Garces Hospital, certain markers are used as ILSEX to predict the diagnosis of sepsis in patients with risk factors. That is why the objective of these dissertations was to determine the levels of serum interleukin 6 in patients sepsis, severe sepsis, and sepsis shock. Conclusion. In this multicenter randomized trial in which patients were identified early in the emergency department as having septic shock, received antibiotics and other non-resuscitation aspect of care promptly, we found no significant advantage with respect to mortality or morbidity or protocol-based resuscitation over basic care that was provided according to the treating physician's judgment.